Good morning, everyone. Last class we have discussed about vertical dimension at rest. Now we are going to discuss the vertical dimension at occlusion. Mainly the mechanical methods, ridge relation, measurement of formal dentures, pre-extraction records. Under the ridge relation, distance from the incisive papilla to the mandibular incisor, parallelism of ridges, measurement of formal dentures, pre-extraction records, profile radiograph, profile photographs, soft wire tracing, face mask, plaster class, and Bill's method, Booth's biometer, and electromyography. Coming to the disadvantage, the equipment is too expensive. Physiological methods, physiological rest position, phonetics and aesthetics, swallowing threshold, closest speaking space, tactile sense and patient's perception of comfort. Mechanical method, in this, the distance from the incisive papilla to the mandibular incisors. The incisive papilla is the stable landmark, and as it changes little with the resorption of ulnar ridge, incisal edge of the maxillary central incisors are an average of 6 mm below the incisive papilla. The tip of the mandibular incisor is at distance of 4 mm from the incisive papilla in an average natural dentition. So the average vertical overlap is about 2 mm as shown in the diagram. Parallelism of the ridges. Sayers in 1926 stated that the paralleling of the maxillary and mandibular ridges plus a 5-degree opening in the posterior region often gives you a clue to the amount of jaw separation. Measurements from previous dentures. These measurements are made between the ridges crest in the maxillary and mandibular dentures with a Rowley gauge and can be correlated with the absorption of patient's face to determine the amount of change required. Pre-extraction records. Profile radiographs. Radiograph before extraction must be taken and preserved. After the extraction and after establishing the tentative jaw relation, another radiograph should be taken. 2 radiographs must be superimposed and compared. The inaccuracies that exist in either the technique or the method of comparing the measurements make these methods unreliable. So you can go through these diagrams. Profile photographs. Profile photographs are made and enlarged to life size. The photograph should be made with the teeth in maximum occlusion. Measurements of anatomical landmarks are compared with the measurement of face using the same landmarks. The disadvantages: angulations of photographs might differ with the patient's posture. Enlargement can cause inaccuracies. Soft lead wire tracing. A soft lead wire is bent to fit the profile of face when the patient is in maximum intercuspation. This lead wire is then carefully placed to fit precisely against the edentulous patient's profile in vertical. It can also be placed on a cardboard and a lead wire outline traced on it. The cardboard is cut along this line and then used to fit against the patient's profile during the jaw relation. Face mask. Swenson in 1959, an alternate impression of the patient face is made. It is reinforced with the plaster before removal. The impression is poured with the stone and a 2 to 3 thickness base plate wax is adapted on the cast. The face mask is then pressed in the clear acrylic. A transparent mask is then placed over the patient face at the time of determining the vertical dimension of the occlusion. At the correct vertical dimension, the mask will fit accurately to the face. Plaster casts. These casts can be obtained with the natural teeth in occlusion, and the measurements can be made between certain relatively stable points such as the incisive papilla and the crest of the lower ridge, extended height of upper and lower buccal frenum, or the hamular notch and the retromolar pad. Coming to the diagnostic casts, various methods to determine the vertical relation of occlusion by using the diagnostic cast. Hens and Peters method, Quinn et al. Method, Bissasu method, Hing and Peters method. Accurate casts of maxillary and mandibular arches are made. Maxillary cast is related to its correct anatomic position on articulator with the face port transfer. An occlusal record with the jaw's eccentric relation is used to mount the mandibular cast. After the teeth has been removed, the edentulous casts are mounted on the articulator. The inter-arch measurements are compared and necessary adjustments are made. They give information of vertical overlap and size and shape of the teeth. Disadvantages. It cannot be used when there is a long waiting period for fabrication of denture after extraction. It can be used when there is excessive bone loss during the extraction procedure. Quinn et al. Method. Quinn et al. Made maxillary and mandibular record bases and wax occlusal ribs, recorded the maxillomandibular relationship and made wax flanges for the delayed areas of diagnostic casts. The maxillary and mandibular record bases, wax flanges and the stone teeth were duplicated in a duplicating flask using a reversible hydrocolloid impression material. The replica wax bases are used for making the definitive impression. The resultant stone cast and the replica wax bases and the wax teeth are mounted in an articulator in the maximal intercuspation, and the artificial teeth are arranged with the impression material in place. The disadvantages are this method requires additional procedure and it is a time consuming. Bissasu method proposed in determining the original vertical relation by measuring the distance between center of the incisive papilla and the incisal edges of maxillary central incisors and between the anterior attachment of the lingual frenum, and then adjusting the maxillary and mandibular wax occlusion ribs anteriorly to correspond with these measurements. Advantages are method is simple, does not require any additional armamentarium. PowerPoint. Ralph Boss PowerPoint in 1940 stated that there was a point of maximum biting power. He says that the patient registered the greatest amount of pressure on a spring dynamometer bimeter at a point. This theory is based on the concept that maximum closing force can be exerted when the mandible is at vertical dimension of rest position. Swallowing threshold. Shanahan Thomas, it is considered that the beginning of swallowing, the teeth of upper and lower jaws almost come in contact. This factor can be used as a guide to determine vertical dimension at occlusion. A conical occlusal rims made of soft wax is fabricated on mandibular record base. The upper and lower record bases are inserted in the patient's mouth. Salivation is stimulated at the patient and the patient asked to swallow. The height of conical wax rims is reduced due to pressure developed while closing during swallowing. Coming to the Silverman closest speaking space. Silverman's in 1953 suggested that the closest speaking space measures the vertical dimensions when the mandible and the muscles involved are in physiological function of speech. When correctly placed, the lower incisors move forward to a position nearly directly under the upper central incisors and come close to them but do not contact is vertical dimension at occlusion as shown in the diagram. You can go to the diagram also. The measurements ranges from 0 to 10 mm. The closest speaking space as measured in the natural dentition must be reproduced in complete dentures up to the loss of remaining natural teeth. The tactile senses. The tactile senses of the patient is used as a guide in the determination of occlusal vertical relation. An adjustable central bearing screw is attached in plate of the maxillary denture basis of occlusion rim. The central bearing plate is attached to the mandibular occlusion rim or trial-based denture base. Central bearing screw is first adjusted so it is obviously too long, that is, the mouth is open beyond the physiological rest position. Then in a progressive step, the screw is adjusted downwards until the patients indicate that the jaws are closing so far. The freeway space and interocclusal distance defines the distance between the vertical dimension of the rest and the vertical dimensions while in occlusion. You can show in the diagram, it is clearly shown. So these are the main differences between the Silverman closest speaking space and freeway space. You can go through this tabular form. Here the dynamic registration, here is static registration. Muscles are full friction. Muscles are at rest. Easy procedure, difficult procedure, reliable procedure, unreliable procedure, repeatable result. Results may not be easily repeatable. Exact measurements in case of freeway space, average measurement. Less chair time, more chair time in case of freeway space. Practical technique, unpractical technique provides a reference position, provides no reference position, there is no variation, there is diurnal variation indefinitely present, unaffected by change of emotions, very much under the influence of changing emotions and the moods in freeway spaces, more accurate when performed on natural teeth, and in case of freeway space, no such shortcoming, checked in the anterior region, checked in premolar region in the case of freeway space. It ranges from 1 to 10 mm in the Silverman closest speaking space. In case of freeway space, it ranges from 2 to 4 mm. So here we'll end the class today, and the next class will further proceed in the next class. Thank you very much.